Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am Dr. Marina Akhtar, PGR Community Medicine. Today my topic of presentation is human papilloma virus. I am presenting this topic under the kind supervision of my professor Dr. Saira Afsal. Hadith of the day. Abu Huraira reported, the messenger of Allah, peace and blessing be upon him, said, whoever travels a path in search of knowledge, Allah make easy for him a path to paradise. Human papilloma virus. Learning outlines. Introduction, epidemiological determinants, chain of transmission and communicability, clinical manifestations, level of preventions, recent advances, and then MCQs. Learning outcomes. At the end of this presentation, the participants will be able to describe the epidemiological determinants of human papilloma virus, its clinical features, prevention strategies, and global updates of HPV. Introduction. Human papilloma virus is the most common sexually transmitted infection. Most sexually active men and women are exposed to the virus at some points during their lifetime. Structure of the virus, small non-enveloped isohedral DNA viruses with 52 to 55 nanometer diameter, single double standard DNA molecule of about 8,000 base pairs that is bound to the cellular histones, a protein capsid composed of 72 pentameric capsomers. Capsid contain two structural proteins, late 1, late 2, both rarely encoded. This picture showing the structure of virus. Problem statement. Globally, 12% of women are positive for HPV DNA, with rates varying by age and country. The highest rate of HPV are in young women, with a rate of 24% in the women under 25 years. Rate declines in older age groups in Europe and America, but less so in Africa and Asia. The rates are highest in the sub-Saharan African 24%, Eastern Europe 21%, lowest in the North America 5%, and Western Asia 2%. Most common types of HPV worldwide are HPV 16, 3.2%, HPV 18, 1.4%, HPV 52, 0.9%, HPV 31, 0.8%, HPV 58, 0.7%. High risk types of HPV are also distributed unevenly, with HPV 16 having a rate of around 13% in Africa and 30% in West and Central Asia. Like many diseases, HPV disproportionately affects low income and resource poor countries. The higher rates of HPV in sub-Saharan Africa, for example, may be related to high exposure to human immunodeficiency virus HIV in the region. This picture showing their adjusted HPV prevalence in percentage in different continents and subcontinents and in the world. Pathogenesis. HPV infection is limited to the basal cells of stratified epithelium. The virus cannot bind to the live tissue. It infects epithelial tissue through the microabrasions or other epithelial trauma that exposes segments of the basement membrane. HP virion associated with receptors such as alpha integrins, laminins, and annexin A2. This picture showing that how pathologically and histologically HPV infect the epithelial cells. HPV infect epithelial cells in the cervical mucosa. HPV DNA integrate into the cellular genome when causing cancer. These are infected cells, and then the virus replicates in the cells. 90% heal within 2 years, and HPV DNA integrated into the tumor a cell DNA, and 0.8% develop cancer. And this picture showing invasive cancer that have invaded the basement membrane. Mucosal, there are two sites of infection, mucosal or genital infection site, non-mucosal or cutaneous infection site. Mucosal and genital infection site include high risk HPV types 16, 18, 31, 33, 45, 52, 58, and others. Uh, they cause high to low grade lesions of genital tract, cervical, anal, penile, vaginal, vulvar, and oropharyngeal cancers. And low risk HPV type 6 and 11 and others. They cause low grade lesions of genital tract, anogenital warts, recurrent respiratory papillomatosis. And a non-mucosal cutaneous infection site cause plantar warts, palmar warts, and other skin warts. Symptoms. HPV may not cause symptoms at once, but they can appear years later. Some types can lead to warts, while others can cause cancer. Warts. Common symptoms of some type of HPV are warts, especially genital warts. Genital warts on cervix or inside the vagina can cause cervical changes, dysplasia that can lead to the cervical cancer. The wart cause these changes, not HPV. Genital warts may appear in the small bump, cluster of bump, or stem-like protrusions. They commonly affect the vulva in women and possibly cervix and penis and scrotum in the man. They may also appear around the anus and the groin. They can range in size, appearance, and be large, small, flat, cauliflower shaped, and may be white or flesh tone. Other warts associated with HPV include common warts, plantar, and flat warts. Common warts are rough, raised bump, most commonly found in the hands, fingers, and elbows. Plantar warts, described as hard, grainy growth on the feet, the most commonly appear on the heels or the ball of feet. Flat warts generally affect children, adolescents, and young adults. They appear as flat top, slightly raised lesion. They are darker than normal skin color and are most commonly found on the face, neck, or areas that have been scratched. This picture showing different types of warts: common warts, filiform wart, flat wart, plantar wart, and periingual wart, mosaic wart, oral wart, and genital wart. Other symptoms are cancers. Other type of HPV can increase the risk of developing cancer. These cancer include cancer of cervix, vulva, vagina, penis, anus, and oropharynx, or the base of the tongue and tonsils. It may take years or decades for cancer to develop. Early all cervical cancer is due to HPV with two types, HPV 16 and HPV 18, accounting for 70% of the cases. These cancers are in common involve sexually transmitted infection of HPV to stratified epithelial tissue. Individuals infected with HPV and HIV have an increased risk of developing cervical or anal cancer. This picture showing different stages of cervical cancer. In stage 1, cancer is found only in the cervix. In stage 2, cancerous cells have spread to the upper part of vagina or the tissue around the uterus. And in stage 3, cancer has spread to the lower part of vagina or the pelvic side wall. Cancerous cells may also have spread to the lymph nodes in the pelvis. And in stage 4, cancer has spread beyond the pelvis to the bladder, rectum, abdomen, liver, and the lungs. This picture showing different signs and symptoms of cervical cancer that includes pain in pelvis, fatigue, unexplained weight loss, heavy vaginal bleeding, bleeding during sexual intercourse, blood taint, vaginal discharge with a strong odor, and rarely there is the presence of vaginal mass, bleeding after pelvic examination, pain in the back and the legs, and lack of appetite and pain in the pelvis. Epidemiological determinants include host, environment, agent, and vector. Agent factor includes human papilloma virus infection. HPV infection is the infection caused by human papilloma virus, a DNA virus from the Papilloma viridae family. Nearly all cervical cancer is due to HPV. Two strains, HPV 16, HPV 18, accounts for 70% of the cases. HPV 16 is responsible for almost 90% of HPV positive oropharyngeal cancers. Transmission. HPV is transmitted through the intimate skin to skin contact with an infected person. Transmission is most common during vaginal, penile, anal, and oral sex. Studies of newly acquired HPV infection demonstrate that infection typically occurs soon after first sexual activity. In a prospective study of the college women, the cumulative incidence of infection was 40% by 24 months after first sexual intercourse, and 10% of infection were caused by HPV 16. Autoinoculation from one body side to another can occur. Very rarely, vertical transmission of HPV from an infected mother to her infant can result in a condition called juvenile onset recurrent respiratory papillomatosis. Reservoir. Humans are the only natural reservoir for HPV. Other viruses in the papilloma virus family affect other species. Temporal pattern. There is no known seasonal variation in the HPV infection. Communicability. HPV is presumed to be communicable during both acute and persistent infection. Communicability can be presumed high because of the large number of new infections estimated to occur each year. Health promotion, the level of prevention in public health. Level of prevention or primary prevention that include health promotion and specific protection. Secondary prevention include early diagnosis and prompt treatment. Tertiary prevention include rehabilitation. Primary prevention uh, and health promotion, avoid skin to skin contact by not having sex with strangers. Use of condoms or the dental dams whenever having sex, having vaginal, anal, and oral sex. Though condoms and dental dams are not as effective as against HPV as they are against other STDs like chlamydia and HIV, safer sex can lower the chance of getting HPV. Specific protection. Three vaccines are available to prevent infection by some HPV types. All protect against initial infection with HPV type 16 and 18, which cause most of the HPV associated cancer cases. Gardasil protect against HPV type 6 and 11, which cause 90% of the genital warts. Quadrivalent vaccine. Cervarix, it is bivalent and it is prepared from virus-like particles, VLP of the L1 capsid protein. Gardasil 9, non-valent, it has the potential to prevent about 90% of the cervical, vulvar, vaginal, and anal cancer. HPV vaccine recommendation. Routine vaccination recommended for females and males at the age 11 to 12 years, minimum age 9 years. Catch-up vaccination is recommended for all persons not adequately vaccinated through the age of 26 years. Catch-up vaccination is not recommended for all adults over the age of 26 years. Shared clinical decision making is recommended for some adults age 27 through 45, not less than for adults over age 45. HPV vaccination schedule, 2-dose series and 3-dose series. In 2-dose series, for immunocompetent person who receive first valid dose before their 15th birthday, it will be on day 0, and second dose will be 16 to 12 months schedule. Minimum interval should be 15 months. And in 3-dose series, for person who received their first valid dose on or after their 15th birthday, for a person with primary or secondary immunocompromising condition, the dose schedule will be at date 0, and then after 1 to 2 months, and then 6 month schedule. High vaccine efficacy. More than 98% of the recipients develop an antibody response to covered HPV types within 1 month after completing series. No evidence of efficacy against disease caused by vaccine types with which participants are infected at the time of vaccination. Prior infection with HPV type did not diminish efficacy of the vaccine against other vaccine HPV types. HPV vaccine contraindication and precautions. Contraindication: severe allergic reaction to vaccine components or following a prior dose, history of immediate hypersensitivity to yeast, and anaphylactic reaction to the latex. Precautions: moderate or severe acute illness defer until symptoms improve. HPV infection during pregnancy. Initiation of the vaccine series should be delayed until after completion of pregnancy. If a woman is found to be pregnant after initiating the vaccination series, the remaining dose should be delayed until after the pregnancy. If vaccine dose has been administered during pregnancy, there is no indication for intervention. Women vaccinated during pregnancy should be reported to the manufacturer. Pregnancy testing is not needed before vaccination. Secondary prevention. Cervical cancer screening. WHO encourages countries to use HPV tests for cervical screening, including HPV DNA, HPV messenger RNA test. HPV DNA tests detect high-risk strains of the HPV, which cause almost all cervical cancer. HPV messenger RNA detect HPV infection leading to cellular transformation. WHO recommends cervical cancer screening should start at from 30 years of age in the general population of the woman, with regular screening with a validation HPV test every 5 to 10 years. From a 25 years of the woman living with HIV, women living with HIV also need to be screened more frequently every 3 to 5 years. Annual cervical cancer screening not recommended for average risk individuals. For age 21 through 29 years, screen with cytology test every year. For age 30 through 65 years, screen with choice of cytology test every 3 years, and HPV test alone every 5 years, or cytology test plus HPV test every 5 years. ACS recommends that screening start at the age of 25 years for average risk person. HPV vaccination does not eliminate the need for cervical cancer screening. Secondary prevention. Diagnosis. The traditional methods for viral diagnosis, such as electron microscopy, cell culture, certain immunological methods, are not suitable for HPV detection. HPV cannot be cultured in the cell culture. The important method for the diagnosis of HPV infections are colposcopy and acetic acid test, and biopsy, DNA test, PSR, southern blot, hybridization, in situ hybridization. Diagnosis: colposcopy, a procedure that allows illuminated stereoscopic and magnified viewing of the cervix. PSR-based methods: HPV DNA can be amplified selectively by a series of reactions that lead to exponential and reducible increase in viral sequence present in biological specimen. Serological assay, ELISA or Western blot analysis. Diagnosis: biopsy. If biopsy results show precancer dysplasia or cancer, then treatment is recommended. The dysplasia may be mild, moderate, or severe. Pap smear or Pap test. It is a screening test. Apart from the pre-malignant and malignant changes, viral infection like HPV infection and herpes can also be detected. Acetic acid test, a vinegar solution applied to HPV infected genital areas turn them white. This may help in identifying difficult to see flat lesions. Pap smear test, early precancerous changes detected on the Pap smear. A woman may have cervical cancer and not know it because she may not have any symptom. A Pap smear is usually part of pelvic examination accompanied by breast examination. A sample of mucus and the cell will be obtained from the cervix and endocervix using a wooden scraper or a small cervical brush or broom, and the sample is rinsed into the vial and sent to the lab for slide preparation and examination. Secondary prevention, in treatment, there is currently no specific treatment for HPV infection. However, warts can be treated by salicylic acid, amiquimod, and podophylox, and trichloroacetic acid. Treatment: surgical and other procedure. If medication does not work, Then the following methods can be used to remove warts: freezing with liquid nitrogen, burning with electrical current, surgical remover, and laser surgery. Well, condom use may reduce the risk for genital human papilloma virus infection. Now coming to the recent advances, WHO response. The Health Assembly adopted the global strategy to accelerate the elimination of cervical cancer as a public health problem. The definition of elimination of cervical cancer has been set up as a country reaching the threshold of less than 4 cases of cervical cancer per 1 lakh women per year. To reach this threshold by the end of 21st century, WHO has set up 90 target to be reached by 2030 and to be maintained. Steps of this strategy includes 90% of the girls fully vaccinated with HPV vaccine by age 15. 70% of women are screened with high performance test by 35 and again by 45 years of age. And 90% of the women identified with cervical disease receive treatment. 90% of women with pre-cancer treated. 90% of women with invasive cancer managed. WHO has developed guidance and tools on how to prevent and control cervical cancer through vaccination. Screening and treatment management of invasive cancer. WHO worked with countries and partners to develop and implement comprehensive programs in line with the global strategy. A global strategy toward eliminating the cervical cancer as a public health problem adopted by World Health Assembly in 2020 recommends a comprehensive approach to the cervical cancer prevention and control. The recommended actions include intervention across the life course. The life course approach for cervical cancer prevention and control. The life course approach for cervical prevention and control, in which population prevalence, this is picture showing population prevalence and age distribution, where HPV infection is common, precancerous stage is common, and cancer stage is common. WHO response. HPV vaccination does not replace cervical cancer screening in countries where HPV vaccine is introduced. Screening programs, population-based base based screening program are needed to identify and treat cervical pre-cancer and cancer to reduce cervical cancer incidence and death. Cervical cancer prevention should encompass a multidisciplinary, including components from community education, social mobilization, vaccination, screening, treatment, and palliative care. Primary prevention includes girl 9 to 14 years of age. There should be HPV vaccination for them. Girls and boys should be offered as appropriate health information and a warning about tobacco use. Sex education are tailored to age and culture. Condom promotion and provision for those engaged in sexual activity, and male circumcision. Secondary prevention includes for 30 years of age of women from general population and 25 years of age women with living with HIV. There should be screening with high performance test equivalent or better than HPV test, followed by immediate treatment or as quickly as possible after an HPV molecular positive test. In tertiary prevention, all women as needed. Treatment include invasive cancer at any age, surgery, radiotherapy, chemotherapy, and palliative care. Cervical cancer elimination country review and roadmap for action. In Pakistan, cervical cancer is the third most common cancer in the woman, with 5,601 new cases, 7.3 per 1 lakh women, and 3,861 deaths, 5.2 per 1 lakh women in 2018. It was predicted that without any intervention, a total of 4 lakh 2,742 women in Pakistan will die from cervical cancer by 2070, and uh, and uh, and 10 lakh 87,028 by 2120. Screening with pap smear test is available in Pakistan. However, coverage is low. There is no national HPV vaccination program. To reach the elimination targets, organized National programs for both HPV vaccination and HPV cancer screening and treatment needed to be implemented with high coverage achieved across the need to be strengthened across all three pillars: HPV vaccination, HPV screening, and treatment for long-term success. On the path toward elimination, Pakistan could eliminate cervical cancer by 2046. There is an article, National Cervical Cancer Burden Estimation through Systematic Review and Analysis of publicly data in Pakistan. The objective of this systematic review is to estimate the burden of cervical cancer in Pakistan using available data source. They perform a systematic review from years 1995 to 2022, study data and identified through systematic review that provide enough information to allow as age-specific incidence rates and age-standardized incident days (ASIR) calculation for cervical cancer were merged. The total 13 16s were included in the study. Among the selected studies, Karachi Cancer Registry reported the highest disease burden estimated for all the reported time period 1995 to 1997. ASIR 6.81 and 1998 to 2002 ASIR were 7.47 and 2017 to 2019 ASIR 6.0 per 1 lakh women using data from Karachi, Punjab, Pakistan, Atomic Energy Cancer Registries 2015 to 2019. They derived an unadjusted ASIR for cervical cancer 4.16 per 1 lakh women, varying model assumption produce adjusted ASIRs ranging from 5.2 to 8.4 per 1 lakh. They derived an adjusted ASIR for 7.60 and estimated 6,166 new cases for cervical cancers per year. Conclusion: the estimated cervical cancer burden in the Pakistan is higher than the WHO target. Estimate the sensitive to the health-seeking behavior, appropriate physician diagnostic intervention, factors that are relevant to the case of the cervical cancer, a stigmatized disease in a lower middle income country setting. This estimate make the case for approaching cervical cancer elimination through a multi-pronged strategy. Now coming to the MCQs. MCQ number 1 is, an XYZ person was diagnosed with HPV, but he currently shows no signs of illness. He is more likely to spread HPV infection through option A, blood transfusion, option B, contaminated food, option C, coughing and sneezing, option D, mosquito bite, option E, sexual contact.
E.
Yes, E is the right answer. A 35-year-old male smoker present with persistent hoarseness of voice with difficulty swallowing for past few years. On examination, you notice a visible growth on his vocal cord. What type of HPV infection is most commonly associated with this presentation? HPV. Option A, HPV 6, HPV 11, HPV 16, HPV 18, and HPV 31. Right answer is
B.
option C, HPV 16. A 30-year-old woman present with persistent abdominal vaginal bleeding between periods. He also report experiencing pain during intercourse. On pelvic examination, you observe a cauliflower-like growth on the cervix. What is the most likely diagnosis? Option A, endometrial polyps. Option B, cervical polyps. Option C, cervical cancer. Option D, cervicitis due to trichomonas vaginalis. Option E, human papilloma virus infection.
E.
Option C is answer, cervical cancer. A 19-year-old male college student present to the University Health Center for HPV vaccination. He asked about the recommended age for HPV vaccination in males. At what age should males ideally receive HPV vaccine for optimal protection against HPV-related disease? Option A, before sexual death. Option B is during adolescent. Option C, before age 30. Option D, anytime during adulthood. Option E, after the age of 40.
B.
Yes, B is the right answer. A 26-year-old sexually active female present to your clinic for her annual checkup. She inquires about ways to prevent HPV infection. Which of the following measures is the most effective for preventing HPV transmission? Option A, avoiding sexual activity altogether. Option B, using condoms consistently and correctly. Option C, limiting the number of sexual partners. Option D is practicing good genital hygiene. Option E is HPV vaccination.
E.
B. Yes, E is the
Option
right
B.
answer. A 45-year-old male presents with multiple erythematosus varices lesion on his penis. He reports that these lesions have been increasing in size and numbers over the past years. What is the most appropriate diagnostic test to confirm the HPV infection in this patient? Option A, Telsen smear. Option B, gram stain. Option C, PCR. Option D, ELISA for HPV antibodies. Option C, KOH preparations. Option C is
C.
right answer. Yes, C is right answer. If a woman is found to be pregnant after initiating the vaccination series of HPV, remaining doses should be delayed until option A, after completion of the first trimester of pregnancy. Option B, after completion of second trimester of pregnancy. Option C, after completion of 8 months of pregnancy. Option D, after completion of 9 months of pregnancy. Option E, in the third trimester of pregnancy.
D.
D is the right option.
A.
D. A 36-year-old sexually active multiparous female presented to the obstetric and gynecological outpatient department with complaint of irregular blood spotting or the light bleeding between periods, increased vaginal discharge, occasionally foul smelling during the past 6 months. The following is the most likely diagnosis of this condition. Option A, breast cancer. Option B, cervical cancer. Option C, endometrial cancer. Option D, ovarian cancer. And option E, uterine cancer.
B.
B.
Yes, B is the right answer. HPV vaccine perform best when given before HPV exposure to prevent cervical cancer. WHO recommend vaccination girl age when the majority have not initiated sexual intercourse. This age should be 9 to 14 years. For option B is 14 to 16 years. Option C 18 to 20 years. Option D is 20 to 22 years. Option E is 23 to 25 years.
A.
Yes, A is the right answer. An XYZ cervical cancer screening program with a high performance test equivalent or better than HPV test, followed by immediate treatment, was initiated in ABC community targeting to the 30 years of age for women from general population. 25 years of age for the women living in HIV. The level of prevention in this scenario is option A, primary prevention. Option B, primordial prevention. Option C, quaternary prevention. Option D, secondary prevention. And option E, tertiary prevention.
D.
Yes, it includes in secondary prevention. This is the key of MCQs, and this is YouTube link of our channel. Kindly like and subscribe, and thank you so much.
Thank you very much, Dr. Marina. Dr. Marina, would you please go to your slides where you have discussed the diagnosis, because they are very important aspects. One is the screening aspect and other is the diagnostic aspect. What I have heard in your presentation is that the screening has been described very well. However, the diagnostic part, that is not sufficient. We know the screening tests are those that are done in healthy population, and once the symptoms are there, we always have to go for the diagnostic test. So would you please go to that slide where you have described the diagnostic test?
Yes, ma'am, these are.
Okay. So what are the sensitivity and specificity of each test?
Sorry, madam, I have not mentioned
Like
in this slide.
So you have to mention not only the screening test, their sensitivity and specificity, their accuracy and yield, but you also have to give the details of the diagnostic tests that are available. And now we know that new tests, they are coming up, and still the PCR is one of a very sensitive and specific test. And ELISA, yes, it is a good test, but the issue is with the specificity of the test. So that should be mentioned in your slides. Otherwise, it is a good presentation. After adding the tests, especially the screening test and the diagnostic test and the sensitivity and specificity of each test along with the accuracy and yield, please share these slides again. Thank you very much and Allah Hafiz.
Thank you, ma'am. Inshallah, ma'am.
Allah Hafiz.